Good afternoon, AHA, and happy 100 years. All right? Look, we need a little bit of a clap. Come on, guys. No. So, Dr. Scaramucci, who did an amazing job with the other panelists, one of the things that you should know this about me is I think the reason why Pat and team chose me to speak today on a Sunday is because I am like a preacher, a Southern Baptist preacher. So I'm going to say happy 100 again, and I want you to be a round of applause. A happy 100, AHA. All right, there you go. So many organizations have come and gone, and the American Heart Association still remains the global leader in heart health, particularly in research, clinical care, and population health management. Most of you may wonder, who am I? I will share with you. I am not the star. The stars of the show are my new best friends, what we call fast friends, and they will introduce themselves pretty soon. My name is Dr. Azizi Seixas. I'm the chair for the Department of Informatics and Health Data Science at the University of Miami Miller School of Medicine. I lead the Media and Innovation Lab, as well as a Sleep and Circadian Sciences Center. And I lead population health informatics for an Institute for Data Science and Computing. So, as you can imagine with my accent, they always say I'm Jamaican and we usually have multiple jobs. And my other job is that I am part of the American Heart Association advisory and work group around digital therapeutics led by our fearless leader, Dr. Patrick Dunn. All right. So today we are going to be talking about how digital health is transforming not just maternal health, but women's health and cardiometabolic and cardio-oncology care. We're going to modify it slightly because we recognize that this, for some of you, may seem as very niche, and we want to ensure, this being one of the last sessions of today, that we want it to be more inclusive. And so if we were to get a little bit of editorial licensing, we're going to say how does digital health is transforming women's health, as well as cardiometabolic kidney, cardiovascular kidney and metabolic syndrome. Our wonderful CEO, Nancy Brown, mentioned that this is an area where the American Heart Association is leading, not just in terms of CKM, in terms of cardiovascular, kidney, and metabolic syndrome, but in terms of women's health with the Go Red Foundation. And there are some really cool initiatives that were just announced. And we are just so happy to be one of the signature sessions talking about how technology can advance that vertical around cardiometabolic kidney syndrome. Now, as you probably know, that cardiovascular kidney and metabolic syndrome is a major issue. And as a result of that, because you're talking and dealing with so many different conditions, you need a multi-pronged approach. And that can be quite, overwhelming for clinicians and scientists alike. And as a result of that, it's really hard for us to wrap our arms around how is it that we care for our patients, how is it that we gather all of these data. And one of the things that one of the subtexts of today's conversation is, can we use technology and digital solutions to be able to capture those data, streamline those data, collate those data in ways in which we can process them, analyze them, interpret them, and then disseminate it to our patients and the entire scientific community and public community. And so I believe that I have the best group to do this today. And so you are in for a treat. I know you will. And with that, I will have them individually introduce themselves for about a minute, please. And if they could talk about why is it that they do what they do, if that's okay. That was, I threw that as a little wrinkle for them because they thought they're just going to give me their titles. And we don't really care about titles, right? You can do that. But we'll start off with Laura. If you could just introduce yourself, briefly, and what brought you here to do the work that you're doing currently, please.
Hello, I'm Lauren Dickerman. I am a women's health physical therapist. I have been treating women for over a decade and truly passionate about cardiac health after having cardiac issues with 2 of my pregnancies. And now here working with the AHA to help them build their cardio-obstetric care plan.
Hi, my name is John Rodis. I'm an obstetrician by training, 20 years of high-risk pregnancy. Then I became a hospital administrator, chief medical officer, chief operating officer, hospital president. I retired to start a consulting company. I'm here now today as an independent director for a company called QC Health, which is a benefit corp, trying to really improve the lives of people and lower the cost for healthcare.
My name is Kris. Vijay, can you all hear me?
Yeah.
Kris Vijay. I'm a preventive cardiologist and a heart failure cardiologist working on two ends of the spectrum of cardiovascular disease. I have a background in nephrology for training in India, and I have a background in endocrinology training from Oxford and Southampton in England, and I have a cardiology training from the United States in Phoenix, Arizona, as a heart failure lipidologist. And I'm being a glutton for punishment, so I'm still learning. I'm going to film school. I don't think there is ever an end to learning process. I'm learning from you, learning from all of you from the previous session. Is it fantastic? And I'm going to come and talk with you after our session because it's all about that. And American Heart is really, educating us, again and again. And I've been part of the AHA for more than 25 years, and I've been part of the Cardiometabolic team and heart failure team in the committees and clinical council of cardiology as well over the number of years. And it's been such an honor and a blessing to be here and to be part of the team who we're going to discuss some specifics over here. Again, thank you.
All right. You guys ready? Okay, so I'm going to join the group. If that's okay. Can you guys hear me? All right. This feels so much better and different. And I have to give my most professional cross-legged, because they don't make this for big guys like me, to be quite honest. So, first of all, thank you all. Really excited about today's conversation. And we're going to start out with Laura, if that's okay. Your background is so unique and dynamic, and one of the things I love about your background is that how you have brought your personhood and your professional background into your work. For those of us who are not familiar with the different apps and solutions that are out there to address the multiple, issues around cardiovascular, kidney, and metabolic syndrome, can you just kind of provide what does that look like in terms of the patients that you see and, what kind of apps that are available or technologies that are available that you use?
Sure. I think that's a great question, and I think that digital tools can be used across the maternal care from preconception to postpartum. And I think one of the easiest ways that we can all access them is through electronic medical record systems. I think that there are tools that could be built in as prompts that would populate risk assessment for an individual that might be at risk for hypertension. I think that these prompts could also deliver timely referrals or populate up-to-date treatment guidelines, and maybe even most importantly, to populate patient education materials, which we know from many of our patients that come into the clinic, they're not receiving enough education from their providers. We know that less than 40% of women are presenting to pregnancy with ideal cardiovascular health, and many of them are living with risk factors or diagnoses and are completely unaware of them. So I think that technologies like remote blood pressure cuffs could be incredibly helpful to help an individual learn about their baseline health and then be able to track their health and for their providers to be able to implement pre-pregnancy strategies and even forecast or anticipate treatment or monitoring that might need to be done during their pregnancies. Continuous glucose monitors and digital scales can be an incredible tool during the preconception period. We know that obesity significantly affects the reproductive aged individual, and obesity comes with significant costs like increased risk of infertility, miscarriage, gestational diabetes, gestational hypertension, risk for C-section delivery. Apps like there are so many apps that are available for exercise guidance and nutrition guidance. Would be an incredible way to help people develop positive lifestyle changes. Even like a simple a Garmin watch or a smart watch with a step count would be a great way for a patient to initiate a simple walking program. During pregnancy, again, I think an electronic medical record system could be incredible. Again, for timely screening, up-to-date treatment strategies, especially like medication recommendations like low-dose aspirin. Most pregnant individuals are turning to apps. In fact, most of them are downloading on average 3 different apps. And these apps are a great tool to increase exposure to education, potentially fill in the gaps of education between visits. When an individual is pregnant, they're having 8 to 14 treatment sessions with their doctors, and within those sessions, many of them aren't getting the education that they're needing. These apps often also provide exercise guidance and nutrition guidance, and many of them provide social support or partner support. Postpartum, I think, is another great area for technology to be used. Telehealth can be an incredibly powerful tool then to decrease barriers and stressors to getting to in-clinic visits. Apps can be a wonderful way to continue to monitor changes such as weight and blood pressure. We know that weight retention is postpartum is a significant risk factor for obesity, and we know that obesity carries significant risks, especially for a woman or an individual that's planning to have subsequent pregnancies. Yeah, I think all of these great technologies could serve so many purposes.
This is fantastic. So before we move on to John, because that was very rich and it shows the depth and breadth of your expertise. If you could just kind of bullet out for us, I heard you say, technologies, devices, solutions can serve as companions. It can help to fill the educational gaps between provider and patients. What are some other benefits? Because I'll turn to John soon to talk about risk, but I'll like for you to kind of enumerate what these benefits are, please.
Well, I think it can decrease the barriers to exercise. I think many pregnant individuals are scared to exercise, and so having guideline-directed exercise programs makes it feel a little bit safer. I also think it's a great way to improve knowledge of nutritional options. Like many individuals don't know what they should be choosing for themselves and their families. And I think it's an incredibly powerful way to connect with other people that might be going through the same experiences. Many of the apps will provide support systems where you can connect with expectant parents that have similar due dates. And I think that's such a powerful thing, especially postpartum, when it can be such an isolating and overwhelming time.
That's amazing. Thank you. So John, not to make you kind of the party pooper of it all, because she speaks about the benefits. With your clinical background, and I know it's quite extensive, so one of the things that many of our audience might be thinking about is, yes, let's not sell technology as a snake oil where it has all benefits and no risks. My question to you, based on clinical practice and in your current role, in venture and industry, what are some potential risks that you are seeing? And what are some risks that our audience, particularly the clinicians, need to look out for in assessing, or implementing these types of technologies in their care or practice or research, please?
Yeah, thank you, Azizi. I'm just going to pick up, if I can, from where Lauren left off, and I think I'll transition to your answer and we'll pass it on to you. I'm going to give you one pregnancy complication that is relevant to cardiologists, right? And I'm just going to pick one, and that's going to be gestational diabetes. And, some people are younger than me. So when I was in training, 2 to 3% of people had gestational diabetes. Today, that's closer to 10%. It's even higher in some populations. And who cares? Why am I talking to cardiologists about gestational diabetes? And Lauren, I already articulated all the great things we do to manage those, right? You have continuous glucose monitors, and we have closed-end now insulin delivery systems, telehealth visits because women are, access to healthcare and You heard the last speaker talk about access to cardiologists. It's the same thing for women's health. OB-GYNs are leaving whole markets, particularly now with the current politics. So telehealth visits play an important role. Continuous glucose monitoring, continuous blood pressure monitoring, so many modalities that are helpful, but they're not the solution to your point. They're an adjunct because there's no substitute for that intervention and direct involvement with the patient, with physicians. But the reason it's important for cardiologists is, and by the way, it's so common that our major journal, cleverly known as the Green Journal, it devoted the entire issue this month to diabetes and pregnancy. The whole issue. Why do we care? Is because, why should you care? 70% of patients with gestational diabetes will become type 2 diabetics in the next 20 years. Now, bear in mind, we're talking about women in their 20s and 30s now, which means they're going to be women in their 40s and 50s with type 2 diabetes. And unfortunately, to your point, we don't do a good job, and this is where the technology can help. We don't do a good job screening them after pregnancy. We've identified them. This pregnancy complication is a window into the future. It's a harbinger of what's to come, and we don't do much about it. We barely even test them again after pregnancy. So we're missing this opportunity to identify these women early and intervene before they see all of you. Because what otherwise will happen is what happens now is they have another baby, they gain another 10 to 20 pounds, they don't lose that weight, then they get hypertension, hyperlipidemia, and now you're starting to get the picture. You know what they look like because you see these patients. They have hyperlipidemia, hypertension, and then they end up with heart failure, MIs, strokes when they're 50s and 60s and 70s. So I think we're missing the boat, really, on this opportunity to identify these people who are telling you, hey, I'm at risk for long-term problems. Now, what happens to those people eventually? They get CKD. So I was thrilled when the presidential advisory came out and identified CKM, and stage 1 CKM was obesity. Because you might wonder, why is diabetes getting more common? Well, 40 years ago, the average pre-pregnancy weight was 130. Today it's 170. To put it in different perspective, when I was a resident, 6% of women at their first prenatal visit were 200 pounds. Today, 10% of women are 300 pounds. So what stage 1 CKM is what? It's excess adiposity. Mm-hmm. So they're going to go on, and eventually they get kidney disease. So let's transition. We could talk about diabetes all day, which, by the way, is the top 10 killer of people in this country and accounts for 25% of the $4.5 trillion healthcare spend. But let's move on to CKD. CKD is also one of the top 10 killers of people, men and women in this country, right? It's been for a long time, by the way. 9 out of 10 people with CKD don't know they have it. It's actually worse than that. You say, how could it be worse? 4 out of 10 with end-stage kidney disease don't know they have it. So I used to show up in my hospital that I was president of in the emergency department with, guess what? Heart failure, because I had fluid retention. I was trying to lower my heart failure readmission rate back then, and I'd say, what's wrong with these patients? And the ED doc would say, well, you have end-stage kidney disease. The patient would say, what? What are you talking about? So now we were stuck putting an IJ in, doing acute hemodialysis, peritoneal dialysis, getting a vascular surgeon to put a fistula in, and eventually they could go on and get dialysis, right? But we had to keep them. It was very expensive. Why didn't they have it done? It's because they weren't getting tested. Even though they were seeing physicians, they were not getting tested. The KDIGO group that you're familiar with, the Kidney Disease Improving Global Outcomes group, 10 years ago published a chart that looks like this. It's a heat map that says you can't just rely on an EGFR. You've got to also measure protein in the urine. Now, I knew 40 years ago that once you have protein in the urine, you're on the road to kidney failure. It's just a matter of time. What we learned in the meantime is you could do something about it, right? ACEs, ARBs, SGL2 inhibitors, stop smoking, don't take NSAIDs, get some sleep, change your diet, manage your blood sugars, manage your blood pressure, and you could delay the progression of kidney disease. Why aren't people doing it? Well, they're just, even though the guidelines are there, they weren't doing it. So the QC Health, the company I worked with, took this KDIGO heat map because we like to identify what we call the golden means, which is a problem that's big enough to matter and small enough to solve. And this seemed like a perfect one. So we started working with health systems and said, hey guys, how are you doing in this? And they said, oh, we're doing good. And when we said, do you have data? And when they all looked at their data, guess what? Like everyone else, only 20% of patients with diabetes and/or hypertension had both tests done. 80% don't, despite the fact this has become a HEDIS measure. People get paid to do it. It's in the chart. Nobody was doing it. So what we did is we said, okay, well, let's work. So we gave a little PowerPoint presentation on how to do it. We created what we call an outcome-guided engagement, which is a digital solution to these problems that could be just bolted onto the EMR, or you could just put it on your desktop. It doesn't even have to be integrated to the EMR. That basically shows you the heat map, prompts you to order the both tests. Once you have both tests, you cross-reference and stage the patient appropriately. We took the 129-page KDIGO recommendations, digested into one page, reminding people to put them on ACEs and ARBs, and SGL2 inhibitor, educate the patient. We created a patient education tool that you just print and hand it to the patient, because they're the ones, by the way, who are suffering the consequences of our mismanagement. And guess what? Well, all of a sudden, we're changing the outcome. So we're making lives better for patients. We're identifying disease earlier, preventing these things from happening, lowering the cost curve all at the same time. So to answer your question, there's a lot you can do, but women are better than guys because they actually go to doctors between the ages of 20 and 45. Men don't. We're bad about this, right? So there's a really opportunity for us to intervene that we should take advantage of.
I love that. And if I were to kind of boil down a nugget of what you said is, especially as it relates to technology and innovation, is that let's not get enamored with new devices and technology, because some of those data are actually already in the electronic medical records. And what you're saying is, how do we harness it and implement it into kind of care pathways to empower providers and therefore our patients? That's
this isn't artificial intelligence. It's like I could write this code in Fortran. I mean, this is really regular, just algorithms.
And I love that. And this is why this is not the health technology pavilion. It's the health innovation pavilion, right? Kris, love to hear your thoughts as to how is it that we could use technology and some of your work and, nearing 3 decades of how is it that we can use innovation technology to do this. And the decade thing wasn't to date you, it was to pay homage to you.
So, fantastic comments, right? So you heard about the 5 W's that we constantly talk about. Who are we targeting? We already know that. Maternal health, for sure. And what about the non-reproductive age? I'll come to that in a minute. And then the second W is the what. We know what the problem is. It's all about those risk factors that we talk about that leads to cardiovascular disease and cardiometabolic disease and the cardiorenal disease or the renal. They're all the same. And the CKM trifecta, the risk factors are all exactly the same. So we shouldn't be isolating them and putting them in a silo. We've got to be talking about them in the same breath. And then we talk about the why. Obviously, the why is very easy. We're going to reduce that big, large outcomes of cardiovascular mortality and beyond. And then now comes the where and the when. That's easy. Here and now. Here and now. There isn't any other. Now, your question, the 5 W's, and then we always forget. The H. How? How do we do it? It's been constantly in our minds. And that's why technology is now intersecting with all of these risk factors. The problem, not just in the United States, but around the world, is that we do reactive care. Once they are pregnant, then we are taking care of them. Okay, do you have hypertension? Do you have diabetes? Do you have this? Okay, let me address you. Let me treat you. Let me make you feel better so that your outcome is better. Same thing happens, the reactive care that you guys talked about as well. Oh, there is a heart attack that's already happened, and then you're now having all of this telemedicine issues, and we do that in the U.S. Around the world, it's exactly the same thing. It's reactive care. So what are we talking about? Secondary prevention as the primary goal. We are so far behind, my friends. It's not only that we got to address the primary prevention, which is address the risk factors so that we control the blood pressure. Did you know that there are 112 million people in the United States with hypertension? And half of them don't even know it, other half not even getting controlled, the other half is not even taking it, they're not reaching the target. That is 47% of the population of the United States have hypertension. What about diabetes? It's only skyrocketing. And we have so many medications in diabetes space. So many medications. There is a new medication for hypertension right there. Go to that booth out there. And we haven't controlled blood pressure? Why do we need so many medications? What is happening out there? We got to be looking at not even primary prevention, which is preventing the outcome from hypertension or diabetes or obesity or cholesterol. We got to be going a step backwards. And what is that? I mean, it's not a step backward. We got to go forward. And that is primordial prevention. Okay, so to your question, primordial is about preventing the onset of hypertension, preventing the onset of diabetes, obesity, cholesterol, all of that, so that we now have somebody who is pregnant, is actually doesn't have any of those issues, and they're having a good outcome. And did you know that United States, in America, we are number 5 in maternal mortality and infant mortality, number 5 in the world? Shame on us. Shame on us. Number 5 in the world for maternal and infant mortality. Do something about it, will you? What are we doing about it? She's doing amazing things, but what about the rest of the country? And where is it happening? We talked about SDOH. Sure. Are we addressing them, or are we giving them access to affordable care? If they cannot afford it, there is no access to care, period. So that's why American Heart is already doing the CKM initiative for pregnant and for people who are not in the reproductive age. 265,000 people are going to be reached. And then they're going to do 150 health services and reaching to like 15 different markets all over. And now they're scaling it up, and they're getting with the guidelines, and they're doing the SDOH component, which is extremely important, address the ones who truly need the care and prevent the onset. So what are we doing? What have I done? I'm speaking about how now. So what did we accomplish? So far, we published this study called the Galvanized Healthy Living. This is an Annals of Global Health. So we've gone all over the world with our nonprofits and collaborating with multiple nonprofits, doing a point-of-care testing. Point-of-care testing in the community setting. So in the community setting, come on over, we are coming, hey, yes, come, bring yourself. And now we do blood testing for point of care, and we do EKG for point of care, and we also did imaging, a carotid ultrasound to detect early atherosclerotic disease, echocardiogram to detect early undetected hypertrophic cardiomyopathy. We detected so many amyloidosis we have detected, valve disease we have detected just by doing echocardiogram, and they or may not be symptomatic. And then we did fibroscan for metabolic disease to look at any early detection of NASH and MASH. Now it's called MASH, metabolic syndrome associated steatohepatitis, and MAFLD. And we also did the INOOC, which is called, the INOOC is about looking at retinopathy and glaucoma, macular degeneration, cataract within 3.5 minutes. So all of this was actually done at one setting, 1,400 patient study that we actually published in Annals of Global Health. And guess what? We found 20% of the population, we reclassified their risk to a higher level. And we detected abnormality in 40% of the population who had absolutely no symptoms. Now suddenly we detected 18% had diabetes or pre-diabetic, and we had 24% of patient population had hypertension, and they had no clue. So we're talking about multiple different heterogeneous population from around the world. So yes, there are some limitations in this and that. So how are we translating this to something beyond? Now we are self-empowerment, teaching them, educating them, putting through workshops for nutritional and food is medicine concept, exercise capacity for 6 weeks of aggressive management with lifestyle modification, and then pharmaceutical help, as you mentioned, many of the RAS blockers and SGLT2s, and then we have a holistic way that we actually do yoga, meditation, Tai Chi. We're calling it Yoga, Bhangra, and Garba. And then now we are also doing the flamenco and salsa, and we're incorporating all of those as a fun thing from an activity perspective. And we're putting it all together now that we did with devices for point of care. Now the new thing that we're doing is called HPOD. So now you may want to look it up. So I'm a consultant for this company called HPOD, which is based out of India through India Health Link. And they have a kiosk model where you just walk into the kiosk and you get 50 different parameters, including you stand on this and you can get all your body weight measurement on this impedance technology, body fat, body index, body bone density. All of them have been validated, accuracy, test, retest, reproducibility, tested, and all the point-of-care blood work is embedded in the kiosk that you get all the results printed out right in front of you. And then now through a high-resolution camera and telehealth, they're talking with a doctor from any part of the world, and they're getting advice, and then now we're putting them through workshops for intervention. What is intervention? All of this lifestyle modification to beyond. So HPOD is here, and now we are starting that in the indigenous population, in Native American, in my state of Arizona, Salt River, Gila River, Akchin, and Tohono O'odham. And we're kicking it off in the United States for the first time with this model in the next 3 months. And the CEO is right here, lives in Chicago at Northwestern, and it has been such a blessing and an honor to be in that space. And I hope we will make some impact. We're doing a registry from day one, data, data, data. Only with data we will know more. Thank you.
This is fantastic. I told you we were in for a treat, right? We have a little bit of a kind of a health revival happening here. And one of the best things I heard is that we have more time. So that's all you guys, So we have more time. So let me play a little bit of angel's advocate. I don't like playing devil's advocate. I'll play a little angel's advocate. So I think your models all sound fantastic, right? But to the healthcare provider at a community health center or a federally qualified health center that may not have the resources, whether it be grant funding or whatever, to set up these very elaborate programs that you have just for screening. But once you've screened someone, it means that you've put more people into a healthcare system that is already stretched. So can we talk about pragmatically, right? How is it that these new innovative modalities can go beyond just the screening or awareness? Can you say a little bit? Because I sense many of the folks out there are just say, yes, sounds great what y'all are doing, but then how do I take it further? Because then if I screen people in a community, it means therefore I now have another 1,000 patients on my hands and I'm already stretched.
So let me address that. So number one, patients who come to Lauren, they are during pregnancy, they realize that they're pregnant, now they're seeking attention, they're already motivated. They're already motivated. That's not the population that we want to be reaching out to, right? So it's interesting, when I was in my middle school, we learning Sanskrit in school, and our teacher was already behind. There were 50 students, and he wanted to take the roll call. And how do I take the roll call and finish 2 chapters? I want to take the roll call quickly. He said, those who are absent, please stand up. Okay, I'm pausing there, and there is a huge meaning to that statement, right? So what are we talking? We're talking about participation bias. If somebody is already participating, which many of you are already here at this large convention, because you're already motivated, you're inspired, you want to learn, whatever. Did you know, I'm from Arizona, there are like hardly 5 cardiologists who are attending this meeting from Arizona, only 5. And there are more than, 1,000 cardiologists in Arizona. 3 or 4 of them are attending. Why is it? Cardiologists don't want to come to attend meetings out there when you go present. I know. What is it that you're going to teach me more than what I already know? And the other joke I do is that what is the difference between God and a cardiologist? God doesn't think he's a cardiologist. I mean, the reason I'm bringing it up is because of the apathy, and I got so much stress in my own life. People, the patients, they don't want to come and participate because they don't feel the need. And then something happens like a heart attack. And then you realize after the fact, oh my God, I should have taken care of my diabetes. I have my friend's uncle just 2 days ago, diabetic ketoacidosis, 1,200 blood sugar, and then not even didn't know that he had diabetes. So this is what we're talking about, bringing them earlier. And if it has to be thousands of people, let's do thousands of people. What is wrong with that picture? I want to know exactly what is your risk earlier so that you take care of yourself. Empowerment, that's what we need.
Thank you. So I was told that we have to wrap up. So we'll give John and then Lauren the final words, if that's okay. These are fantastic points. I think what this indicates is that we probably need a follow-up to this. And I think this is quite a stimulating conversation. So I don't know, John, if you want to...
Yeah, no, I'll just be real quick. I think we have failed, honestly, as a specialty, as physicians in general, OBGYNs in particular. What I mean by that, we've broken the body up into these parts. We teach our medical students diagnosis and treatment. We don't teach about the continuum of disease like this wrote. You start with you're normal, you're healthy. I deliver these people. They're not sick at birth, 2 to 3% of birth defects. The rest of them are healthy, normal little kids. What happens? They get heavy, they get diabetes, they got hypertension, they got hyperlipidemia, and then they have freaking strokes and heart attacks, and then they're all seeing you guys. We don't do anything along the way. We need to, and we're very paternalistic. I'll be honest with you. We don't, not only do we treat the disease and not the continuum, but we don't even, half the patients who have kidney disease that actually are diagnosed, we don't even tell them because we don't want to upset the patient. They're the ones who are suffering the consequences. And the last comment I'll just make is in pregnancy, no one's more motivated than pregnant women. We should take advantage of this and not just talk. I stopped talking about fasting blood sugars and 2-hour postprandials. I said, if you want to see this fetus walk down the aisle or graduate college someday, you should pay attention to what we're telling you.
Thank you. Lauren, sorry to do this to you. 30 seconds. Last words.
Sure, I could do that. I think for me, education has to start earlier. I think if we're talking about the female population or the potentially reproductive age population, they're meeting with a gynecologist at about age 15. We should be starting their education at that point and really hammering in preventative strategies to help mitigate things like diabetes and obesity down the road, and really maybe even educate them on how do you take a blood pressure and what does that mean for you. And so, yeah, education earlier in life, I think, is going to be the key for success.
All right, thank you. Thank you all so much. I'm sure we kept our finalists quite anxious, so we're building anticipation. But huge shout out to Dr. Patrick Dunn and team for giving us the opportunity.
Thank you very much.
For a fantastic presentation. Thank you so much.